There we go. We had 146 people register, Marlene, and we usually get about 50%.
That's
40,
great. I'm sure
40 to
people are coming in
50%.
on their each time. That's
Yeah.
great. That's awesome.
And what's amazing to me is I should do a plug about subscribing to our YouTube channel because our YouTube, well, my husband keeps telling me that might be a way of us being able to fund the community practice a bit more is through our subscriptions to our YouTube channel, or just, through the YouTube channel getting lots of views because our webinars that we have on the YouTube channel are really quite highly watched. One of the webinars has over 13,000 views, which is a lot more than the others, but the others range around anywhere from 2 to 500 views is not uncommon. So, and I have heard from in our feedback surveys and such, people often commented about appreciating the webinars being recorded because they're not always able to be there. And so there was one recently that we did, I guess last spring, winter, and we only had about 30 people. And we were like, oh, where is everybody? But then that webinar got something like, 390 views or something like that. So even though it might be sometimes a small audience, sometimes that doesn't mean that, it wasn't worthwhile doing because lots of people get to see it. Okay, let's get started. It does look like we're a small group so far right now, but let's get started, and we can be rolling when people join us. Um, so welcome everyone. This is a Research Spotlight webinar. We do the Research Spotlight webinars so that we can focus on and highlight the research that is being done related to prescribed alternatives, or otherwise known as Safer Supply. And really happy to be having this one. We haven't had one for a while just because of the team capacity, not due to a lack of research happening. There's so much going on right now. So yeah, really happy to be here. For those of you who do not know me, my name is Rebecca Penn. And I'm the project manager for the National Safer Supply Community of Practice, and I work with London Intercommunity Health Centre. I'm a settler currently living in Mi'kma'ki, or what is colonially known as Nova Scotia. And yeah, very happy to be hosting this webinar today. Also, just want to give a quick shout out to my colleagues, Tanya and Katie, for helping out. They're members of the community of practice and supporting me today with hosting the webinar. So thank you both. Okay, so today our research spotlight is focused in on the Safer Supply Ottawa evaluation report. So happy to be happy to be showing you that today. But before we get started, let's start with acknowledging our colonial past and present. Um, and I want to start off with acknowledging that we're coming together from across Turtle Island as people who live on treaty lands and ceded and unceded territories. In fact, today in Nova Scotia, it is Treaty Day, a day to acknowledge the treaties that are in place in Nova Scotia. Our team and community of practice members are comprised of individuals and organizations from across Turtle Island, though. We're all treaty people. We work in a sector whose goal is to address social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking in our ongoing daily lives. We know that Indigenous people, as well as members of the African, Caribbean, and Black communities, are disproportionately harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today, and we commit to working in ways that transform racist and colonial institutions and practices. and work towards making our world a more just and equitable place. Sorry for skipping there. So if you do want to take a moment to introduce yourself, we'd love to hear who's joining us and where you're joining us from. A little bit of housekeeping. We are recording this event and we will be sharing it on our website along with other resources that are referred to in the presentation. So that will include, we will be sharing the report on our website with the recording, as well as on our webpage for program evaluations. You'll find that English closed captioning is enabled, so you just press the closed captioning and you'll find that showing up for you. We're going to have a presentation followed by a discussion. If you have questions for our presenter, Marlene, you can use the Q&A box and we'll address those afterwards. If you put them in the chat, they get lost. So best is to put them in the Q&A box. I'm also going to do a poll about halfway through, or actually just as we move from presentation to discussion. Getting the results of the poll helps us with applying for funding and reporting to our funders. So please do complete that poll and our survey. And finally, we will have a certificate of attendance available. We'll share that, share a link for that. For those of you who are not familiar with the community of practice, very quickly, we are a knowledge exchange and capacity building initiative that's based out of the London Intercommunity Health Centre. Our goal is to support safer supply programs, but also our goal has really morphed to support the development to an accessible evidence-based continuum of substance use healthcare options for people who use drugs. So that needs to be inclusive of harm reduction, as well as other evidence-based approaches, including opioid agonist treatment and whatever other options work for the people who are looking for that support. Our membership is at almost 1,800 people. And if you're not a member already, I do encourage you to join. Our membership is interdisciplinary with people who use drugs, social care providers, healthcare providers, pharmacists, researchers, policy makers. Yeah, lots of different folks. And we do have clinical consultation services and meetings. So if you are a prescriber or a healthcare provider interested in learning about how to include prescribed alternatives as one of the tools in your toolbox, reach out. We also provide program support. We do education and knowledge exchange, like through these webinars, and have a great Thursday drop-in meeting, which is an interdisciplinary space. Yeah. Coming up, we've got another research spotlight happening at the end of the month. We have a program evaluation from Northwest Community Health Center, and that's happening on Thursday, October 31st from 12 to 1:30 Eastern. And we'll pop the registration link in the chat for you. And then in November, we're excited. We've got a group of folks coming to talk about rebuilding workplace substance use policy and doing that from a harm reduction lens. That will be November 21st. And that one is at 2 p.m. Eastern that day. Usually we have our webinars at noon, but this time it'll be Eastern. And like I say, we'll have a certificate of attendance about halfway through. We'll pop the link in the chat. And I want to encourage you to join the community practice if you haven't already, or at least check out our website. We have tons of resources there, including archives of our webinars. And that's enough of me. I'm very happy to pass it over to you, Marlene. I'll let you take it from here. Thank you.
Great. Okay. Can people see the slides over here? Hold on. Maybe that's not working. Let me try one more time. Share. this one not working. Can someone confirm if that's working? Yeah, it looks okay. Perfect. Great. Okay. So thank you everyone for coming today. I really appreciate you all taking your lunch break or whatever it might be to join me as I kind of talk about what we've been working on for research here in Ottawa. So my name is Marlene. I'm a registered nurse, and for the past few years, I've been overseeing the Safer Supply Ottawa evaluations. Before that, I worked clinically in the programs and absolutely loved my time doing that. And so we've done a couple of these reports over the years, and this is our newest one. I believe it's our fourth that I'll be kind of discussing with you today. So over the course of today, we're going to look at I'm going to give you a brief overview of the program in general. I'm going to then jump into kind of what the actual study was that we did this time for the research and evaluation portion. So this will include some survey results, some interview results, and then also some future considerations. So just very briefly, for those of you who may not be familiar with the program here in Ottawa, so Ottawa brings together 7 different organizations that are all working towards providing comprehensive care and services for the community of people who use drugs. So there are 3 prescribing sites that you can see at the top there, which includes Somerset West, Ottawa Intercity Health and Recovery Care. And then they, with the prescribing, they also provide things like primary care and sometimes supervised injection services where they're linked up for the programs that are linked up with, for example, a supervised consumption site. And then we have our really essential, really important kind of supporting partners who include places like Sandy Hill that does intensive case management for the clients and offers lots of great peer connections. There's Respect Pharmacy that does some home deliveries for people and offers pro bono meds for people when they're kind of having periodic drug coverage issues. Ottawa Public Health has been really essential in kind of helping us to create guidelines and policies that make sense for our clients. And also they continue to collect citywide data on substance use and related outcomes, which is great. And then Options by Town as well has been a fantastic partner, and they do kind of on-site housing workers and really take a focus on people who are homeless or people who are kind of precariously or unstably housed. And then just to kind of give, I won't go through this entire slide. It's been in all of our reports so far, and it will be in this one as well. But just to kind of give an overview of the philosophy of care. So even though we have all of these different partners kind of working together, really at the end of the day, despite day-to-day program differences and operations and things like that, you know, the philosophy of care as well as the ethical and kind of moral standing and beliefs of the program as a whole remain really, really cohesive, which has been really fantastic over the past few years. So taking a focus on things like making sure people who use drugs are partners in care, you know, being committed to lifelong learning and altering the programs when it's needed, advocating for things like drug decriminalization, things like that. So that's always kind of grounded us and brought everyone together in their similarities. So normally I have, and you probably saw on the invitation or the email that you got, that I normally have Athena, who does a lot of kind of the data collection chart review stuff. She couldn't be here today. All of her data will be available in the report, and there's no major changes from previous reports, but it will be fun to kind of see in there. So, but since she's not here today, I just thought I'd give a really brief overview of just to say we have kind of multiple different types of programs. So certainly the Safer Opiate Supply program is the most popular, followed by kind of a combination program when people are given opiates and stimulants. And then people who are just on stimulants alone kind of are the smallest, but still very important group, for a total of 470 participants. This data, I believe, was collected a while ago, maybe 6 months plus. So I think the programs have even grown since then, but still, you know, looking after and partnering with a large group of people who use drugs and kind of providing care to them. So I'm going to jump right into the research that we did for the evaluation, which was really a lot of fun, and we kind of carried out over this past summer. So what we wanted to focus on, because if I think back to our previous reports, the first report kind of looked at the program as a whole with a focus on opiates. The second report dialed in really to stimulants and did more like chart reviews on people who were on the stimulant program alone. And then the third report looked at people who we wanted to understand more the kind of gaps in care where people who were frequently being restarted on the program. So people who were having troubles with, being able to stick to the program regularly. We noticed that the clients brought it up and we wanted to understand it more. So those were all really fantastic projects. But for this upcoming project, something that we were noting though, and I'm sure many of you can speak to this from your communities as well, as there's continues to be so many harms to people who use stimulants. The drug supply continues to, become increasingly toxic for everyone. But I think what's really important to call out is the fact that there just simply aren't a lot of options for people who use stimulants. Not to say that what we have for people who use opiates is enough either, but certainly there is more of a spectrum of services available for people who use opiates. Whereas, there is no gold standard, for example, medication necessarily that everyone kind of agrees upon for people who use stimulants. And there are not a lot of safer stimulant supply programs available across the country. And so we thought that was a really important thing to focus on. So we decided to focus on safer stimulants. Again, kind of given the limited evidence surrounding this topic. And we really did want to understand, participant outcomes and just speak to them and complete a more in-depth exploration of the impact of the program from their perspective. So briefly, the research objectives were to kind of evaluate the outcomes of safer stimulants, to kind of really get into and better understand the motivations and experiences of being on this type of program, to explore the facilitators and barriers of this program, and then also to inform those future directions, because we're always looking ahead about what can we change, what needs to change, how can we improve, and how can we look ahead. The research questions then involved things like, directly asking people about the impact of participating, what sorts of kind of personal health and behavioral changes they might be experiencing that are important to them, and are they able to meet the goals that they set out to achieve when they first joined the program. So we did surveys and interviews with 27 participants across the 2 current Safer Stimulant Supply sites. So although there's 3 prescribing sites, 2 of them offer safer stimulants at this time, which includes Recovery Care in Somerset West. So the interviews were semi-structured. They took anywhere from 15 to 60 minutes, depending on how much people had to say. And we used a thematic analysis to kind of analyze the interview transcripts afterwards. The surveys were important and they were completed to collect information about participant sociodemographic data and self-reports about changes to health and substance use behaviors. Participants were compensated $100 cash for their time and expertise for kind of spending time with us and really teaching us about how things have been going. So just to really roughly break it down, like I said, it was 27 people, and we spoke from 8 people from Somerset West, and then the remaining 19 from Recovery Care. And you see 2 different Recovery Cares there because they do have multiple sites across the city, which is great for clients to be able to access depending on where they're coming from. But the main ones are Byward, which is kind of like our downtown, and Vanier as well. So yeah. Jumping into demographics, participants had a median age of 40 years. They had a median time on Safer Supply of 18 months. Just over half of the participants were men. The majority of people were born in Canada, and 16 participants reported their ethnicity as white, 7 as Indigenous, and 4 as other. I do want to point out that things are grouped under the heading other or are grouped like this to protect patient confidentiality, because of course, with a small sample size and 27 people, and with the particular focusing on safer stimulants, which is again an even smaller group compared to kind of the larger safer supply cohort here in Ottawa. We just want to make sure that we're not giving any sort of information that could cause somebody to know who it was that participated. So I just wanted to point out that that's what the other is there for. And then men and women, cis and transgender were also grouped together, again, for the same reasons, to protect confidentiality, just because there were so few people who identified as transgender. So most participants reported their sexual orientation to be heterosexual. Almost 3/4 of the participants said that they only spoke English. And most commonly, people said that the highest level of education that they completed was less than high school. We did ask participants, similar again to previous reports, about their lifetime drug use. So you can see that, crack cocaine, fentanyl, and hydromorphone were the most common. Everybody said that they had used it at one point or another across their lifespan. And then the median age when participants first used drugs was 14, and the median age when participants began to use stimulants was 18. And I want you to really try and remember these numbers for when we get into the quotes and the interviews, because I think it helps to contextualize some of the themes that really kind of came out during analysis. Um, so for substance use complications before they started the Safer Supply program, we kind of asked participants to reflect back on what was happening at that time in their life. So all participants reported some form of a complication as a direct result of their unregulated drug use before they started the program. So most commonly, people spoke about things like feeling like they had to, or feeling like they had to or were forced to participate in criminalized behaviors, kind of experiencing legal issues, and then as well, hepatitis C infections were also really commonly discussed. So when we ask participants about where they use drugs in general, I think this is really important to understand what's happening in the community, where are resources needed, where are supports needed. And so people mostly spoke about that they were using substances most commonly either at their own home or at someone else's house, followed by supervised consumption sites and then public and shelter. And then we have 4 consumption sites in the city. And so people most commonly reported using at one of the downtown ones, which was Ottawa Inner City Health, followed by Somerset West. So with regards to accessing harm reduction services, several participants noted that they found it really easy to access different harm reduction services because commonly their programs, the Safer Supply programs themselves, housed some of these harm reduction services. So this became, a really convenient thing for them. So for example, with the take-home naloxone, any of the Safer Supply programs will have that very readily accessible and easy for clients to get. Or if they're wanting to do things like picking up sterile supplies, again, they can do that right within their program. So participants were certainly accessing harm reduction services on a really regular basis. So looking at kind of pre and post self-reported measures for clients, we felt that these were important findings to be able to understand kind of how Safe Supply might be impacting things, again, from the client perspective. So for mental health, we asked people to rate their mental health from a scale of 0 to 5, with 0 being poor and 5 being excellent, before and after the program. So before, Safer Supply participants reported a median score of 2 out of 5. And after, they reported a median score, or currently being in the program, they reported a median score for mental health of 4 out of 5. So an interesting change just to note there. With overdoses, we asked people to report if they were experiencing any drug overdoses before the program. And then again, since starting, interestingly, more than half of the participants reported experiencing an overdose event before starting the program. But then since starting the program, the majority have not experienced an overdose event since. Something that I think is important is this graph really does fail to capture the impact that Safer Supply has had. What I mean by this is several participants reported that before Safer Supply, they were overdosing daily or multiple times a day. And then since joining the program, they've experienced maybe 1 or 2 overdose events total, unrelated to their Safer Supply medication. But this group who has experienced 1 or 2 overdoses since starting would still be included within this kind of any overdose event afterwards group. So although we didn't quantify that, and I think that's something that would be useful to do in the future, I just wanted to point that out. So participants were also asked about how their unregulated stimulant use has changed. This can, of course, be a really difficult thing to quantify. I'm sure everyone here, clinicians, researchers, anybody, people with lived experience, it can be really hard to nail down exactly what you're using each day, especially with how, toxic and how fluctuating the drug supply is day to day. But people were able to kind of give us kind of estimates over time. So, and this was important too, because one of the most commonly expressed goals of participants was to change their drug use in some form. So before starting the program, people reported using a median of 10 points of crack cocaine a day, or about a gram. And since being on the program, participants reported using a median of 1 point a day. And so the same thing for crystal meth. Before starting the program, people reported using a median of 5 points a day. And since being on Safer Supply, participants reported using a median of 0 points per day. This was really amazing to hear from the perspective of clients. Of course, I do want to point out that we used median, and median, when it says 0 points a day, it doesn't, of course, mean that everybody's using 0 points per day, but just that was kind of the median number that was given out. And we use median too because it does tend to be more of a conservative estimate of things, especially when you're working with kind of smaller groups like this. So this is kind of how we wanted to approach this, kind of speaking with people. But even then, again, really interesting to see kind of from their perspective the changes in their substance use. Really exciting. And the number of people who reported being housed increased substantially to 21. I think for anyone who's worked in shelters or works with people who are unstably housed, or people who are experiencing homelessness, you know that it can take a really long time, even with all the effort being made to find someone housing. And so I think just thinking back again to that 18-month median of people being on the program, this is a really interesting thing to consider as well. Anecdotally, people spoke about things like that wraparound care, the peers, the housing workers, and the stability that they receive from the program being really essential to them being able to find housing. And then as it relates to income before starting the program, not everybody might not know, not everyone may know these exact programs, but nearly half the participants were on Ontario Works. 41% were on ODSP, or Ontario Disability Support Program, and 4 were reporting another source of income. And since joining the program, the majority of participants were receiving ODSP. I think what this says is, getting on ODSP can be arduous. I've filled out many applications in my time. There's lots and lots of paperwork to do, and supporting things that you need to attach. And I think that, it's people reported, and again, anecdotally, that getting onto the program helped them to be able to do that. They got access to, supports and people who could assist them with being able to get on access to services that they were qualified for. As for criminalized behavior, most people said that they were engaging in some form of criminalized behavior before doing Safe Supply. And then since starting, almost 2/3 reported no longer engaging. I think what's important as well is that among the remaining participants who continued to engage in criminalized behavior, all of them reported that their criminalized behavior had decreased since starting the program. And so to better understand criminalized behavior, they were asked to kind of indicate the types of behaviors they were participating in before and after Safe Supply, if any. And so overall, participants reported a decrease in all categories of criminalized behaviors after joining the program, and with drug dealing being the most impacted, with a 40% decrease, followed by theft with a 29% decrease. So now we're going to get into the interview results, which I always find is really exciting because we get to hear from the people themselves, which is so important when we're considering their care, and how we can best support them. So there's 3 kind of major themes we're going to walk through together today, starting with survival. So that first theme of survival really came through quite clearly. The focus of the study was to better understand the experience of participating in a Safer Stimulant Supply program. But with qualitative research and semi-structured interviews, it's always, of course, as many of you I'm sure know, really important to also allow the participants to take the interviews where they feel the interview should go, based on kind of what you're talking about that day. Just, the semi-structured nature of things. And so many participants wanted to discuss their life before the program, and they felt this was essential to contextualize their current experiences. Participants spoke about things like how prior to program engagement, their focus day to day was on meeting basic needs and just surviving. And that engaging in these survival behaviors was largely driven by kind of the impacts of poverty, substance use, and mental health challenges, and homelessness. So the first sub-theme, there are a few sub-themes to go through, but the first one is survival behaviors. So many participants described feeling like they didn't have a choice but to engage in specific survival behaviors to meet their basic needs. So this included things like the need to purchase unregulated drugs to avoid adverse drug withdrawal symptoms prior to starting the program. Some of these behaviors, such as survival sex work, theft, unregulated drug trafficking, place people at really high risk for things like incarceration, as well as physical and psychological harm. So people, you can see the quotes on the slide, but people were talking about feeling like they were being put in spots that no one should have to. I'd have to do things just to meet my basic needs, etc. And I'm going to move through these slides, but all of this will be available in the report because there's going to be lots of quotes that we go through. So the second sub-theme is about people feeling a loss of control over their lives. So they expressed feeling out of control and the high levels of, effort, energy, income, and time that were exerted within kind of this, how they describe this tumultuous cycle of substance use. So people described how unregulated substances really took control of many aspects of their daily lives, leaving almost no room for anything that they wanted to do in a day. So people, you can see that quote, the second quote there is a never ending story. People talking about their life being out of control, the circle that kept going. And so people are really painting a picture again of this kind of tumultuous cycle that they got caught up in and just were not sure of how to get out of. So the next sub-theme is about shame. People were really clear that before starting the program, they felt a lot of shame regarding their unregulated substance use. So they expressed, things like feelings of disappointment and worry about how the unregulated substance use was impacting not only their own lives, but also really important and essential relationships in their lives. Several participants spoke about shame regarding the impact of substance use, and their identities as parents. They voiced a really clear desire that this is something that they wanted to change. They wanted to be more involved, many of them, and that, starting Safe Supply was kind of a thing that they grabbed onto too, to try to do that. So people feeling disappointed in themselves and, wanting to be able to care for their children and make sure that what happened to them doesn't happen to their children. So the sub-theme of lack of connection and stigma also kind of came up. So people again spoke about losing social supports and connections that really does, again, tie into that previous sub-theme that we were talking about. So they spoke about, for example, their family kind of misunderstanding what it means to use unregulated substances or why they were using them. And it caused major issues for their relationships overall. They said they felt like so many important social supports that they had in their lives just didn't understand the challenges of substance use. And that participants kind of felt that lack of support and eventually ended up hiding their substance use from family or family and friends to avoid judgment. People spoke about things like feeling suicidal, desperation, not wanting to feel judged, like certain types of substances are accepted and certain types of substances are not. So these were just a couple of the really powerful quotes that people spoke about. And then the final sub-theme for this larger first theme is health and safety concerns. So a number of participants did speak about kind of when they were prior to Safer Supply, the safety concerns that they experienced, particularly around homelessness or being unstably housed. So people spoke about being in a state of hypervigilance due to concerns related to theft of their personal belongings or stress regarding their personal safety. Participants also spoke about, that prior to the program, they felt like they had no choice but to engage in this toxic drug supply due to a lack of resources and programs for people who use stimulants. And many of them experienced these negative kind of health impacts from using unregulated substances or stimulants as well. So the second theme is self-medication. This was a really unique theme that nothing kind of like this has come up in previous research or reports that we've done. So this came out really clearly from speaking with participants. So people kind of commonly shared information, again, contextualizing their substance use about when, how, and why they started using stimulants. They wanted to speak about these experiences in detail because they felt like this context was so essential to understanding the current impact of the programs that they were part of. So they shared, how unregulated substances at one point helped them to address unmanaged concerns that they were experiencing. So things like early childhood development challenges and ongoing mental health struggles that they just couldn't find help with elsewhere. Participants also spoke about using unregulated stimulants as a form of self-medication to fill the gaps that they were experiencing as a result of poor or inadequate care. So in this first sub-theme, participants really clearly recounted living through challenging and complex childhoods. So that's why when I said kind of remember these kind of that median age of 14 when they started using drugs, there were some people that were younger than that. That was just the median. And then 18 when they started using stimulants. So many participants spoke about having really early memories of struggling with school and the impact that this had on their ability to continue in school at all. People spoke about also traumatic events surrounded their early years, such as physical abuse and other harms that they faced. So you can see that people are speaking about not being able to concentrate in school or feeling like it was a missed opportunity. Like maybe I would have completed my high school if I had been appropriate, if my treatment had been appropriately managed and my kind of things like perhaps ADHD had been pointed out earlier if I had kind of more comprehensive care. People speak about, still struggling with traumatic memories from their childhood and kind of learning to learning coping skills to kind of deal with those things that come from those traumatic memories over time. And people commonly spoke about as well being part of kind of the CAS, which you'll see a little bit more on the next slide, I believe, and institutionalization that happens with certain people. So yes, institutionalization. So people spoke about kind of having early involvement with the child welfare system. Some people spoke about being incarcerated from a really young age. The first quote at the top is a really beautiful one where this person really clearly was sharing, maybe if I had had certain things in life, this isn't how things would have turned out for me. And that it's not so easy to conform to what society thinks you should do, particularly when you've been institutionalized, and particularly when you've been institutionalized for years or decades of your life. That last person spoke about from 16 onwards being incarcerated, and then early substance use initiation as well. So many people through the survey or through the interviews spoke about starting to use substances at a young age and not really having support in kind of addressing and managing that and understanding kind of what was happening. So the second sub-theme here is about mental health concerns. So almost all participants spoke about struggling with their mental health before starting the program. Some people reported using stimulants or other drugs to help cope with distressing mental health symptoms. And additionally, many people self-described as neurodivergent during their interviews. And many of them reported either having a confirmed or suspected diagnosis of ADHD. So you can see that people, speak about the fact that although eventually unregulated stimulants came to be something that was really dangerous for them, overall as well. So the final theme is program engagement. And so this is where all of the things about how people are perceiving and experiencing their programs now, how that is going, and then the impact of the program on them as well. So they spoke about these experiences as well as what it meant for them personally to be a participant, someone who is part of this program. So the first sub-theme of program satisfaction, participants described really positive experiences, and largely the things that people spoke about when they spoke about the program were positive experiences and the ways that they felt it enhanced their lives. So they spoke about things like having reliable access to pharmaceutical grade medication led to a lot of different positive changes in their life. They speak about things like their mental health improving and feeling more confident and overall better about themselves. They also really clearly denoted kind of that wraparound support care and how important that was. Again, things like that primary care, that, those housing workers, the social supports, the peer engagement, all of these things are what makes the program work. It's not simply about a prescription, it's about a lot more than that. And they spoke about that quite clearly. They spoke about feeling hopeful for the future for the first time in years, and that they never would have imagined being able to get here. And they also spoke about how the program helps them in focusing on their goals. It helps them kind of really orient themselves to making these small steps towards what they want, and it gives them a way to do that with a team around them. So the second sub-theme is about supportive program relationships. So participants reported really positive relationships with care providers that influence the success and commitment to the program. So they spoke about, supportive and non-judgmental relationships with care providers. And they talked about the fact that these were really important, and it allowed them to open up about their substance use goals. They didn't have to give an answer that they thought somebody wanted to hear. It could be an honest answer that was true to what they wanted in their life. They appreciated the opportunity to have check-ins over time with people who were asking about their well-being and were able to support them with the issues they were facing. And they did describe how comfortable they were at disclosing things with staff. Most people felt overall that they could be honest with their prescribers, and didn't feel like their program would necessarily be, threatened with one little thing going wrong. And they described how, they were comfortable disclosing things and their expertise was validated and valued. Although the focus was on positives, I think, of course, it's important to highlight that there were gaps when considering, especially the future of Safer Supply. Every program is going to have gaps and areas to grow, and Safer Supply is not necessarily unique to that. So people did speak about a lack of carries. So people typically, not everyone, but many people had to go to the pharmacy each day to get their medication. Some people over time were given the ability to take a couple of days worth to go with them, but most people were going each day to the pharmacy to get their medication. And people spoke about the fact that it does make meeting certain goals difficult, like reconnecting with people out of town, traveling, or flexibility when looking for work. As well, there aren't a lot of, like I started with by saying, there aren't a lot of Safer Stimulant Supply programs. So, if you want to go visit family for an extended period of time, even in another province, that can be really, really hard. Weekly appointments typically are how the programs run. Again, some people are every 2 to 3 to 4 weeks, depending on kind of their goals and where they're at in the program. But people spoke about kind of how in the beginning the weekly appointments were really important to them. It kind of kept them on track, gave them something to center their life around and maintain them on like a schedule. But they did say that over time they would like things to speed up a little bit more with kind of relaxing on how often they're checking in. And again, some programs do this faster than others, and it also depends on the individual prescribers within each of the programs. Program capacity. So people spoke about, having struggles in getting started to begin with because there are so few spots. There is a huge need for Safer Supply in Ottawa, as I know there is in all of your communities as well. And so while we do have a number of programs, it simply is not even close to enough. And so, people did say, I was on a wait list for a little while, or I would have to check in pretty frequently to be able to get access to the program. And that, was distressing for them personally. But then being on the program now, it was also distressing to them for their, peers, people in their community, and worrying about other people not having access to the program who might need it. And then finally, people spoke about wanting more drug options. So they spoke about, that people did like the options that they were being given for kind of that short acting Ritalin, and then the long acting methylphenidate, which is outlined in the second report. You can kind of see more clearly all the different medication options that are part of being on a safer stimulant program here in Ottawa, at least kind of what the Ottawa programs offer. But they wanted more. They wanted more options. They wanted more availability of things because not everyone is the same. And Just like, if you're starting a new antidepressant or you're starting a new medication, usually you have to try a few different ones before you kind of get to the thing that works really well for you. And so they were asking for the same thing with regards to their stimulant use. So, with substance use changes over time, participants described this really clearly as well. So, this kind of took on a couple of different forms. And I think it's also important to say that for almost everyone, making changes to substance use was an ongoing process that took time. It was not always a clear linear path. It was not always a jump from, A to Z. There were lots of steps in between. And I think it's important, specifically and particularly for the clinicians in the room, to understand that this is a process and that's an expectation that this is a process, that no one is going to be able to go kind of or I've never met anyone who can start the program and be jumping through all of these kind of different goals. It's a process, and that's a great thing. People make steps, bit by bit, and that Safe Supply gives them the space to do this. And it gives them the space to not rush into big changes that can be, quite frankly, just really scary. It also offered people feeling more control over their own life, having more freedom to make decisions collaboratively for what worked for them. So, people speaking about, you could see the top left bubble, somebody speaking about now they're hoping to cut down on their safer stimulants. They were able to kind of get onto a dose that works for them, but they do want to decrease over time. For other people, that might not be their goal. Some people spoke about, it's work, it takes time, nothing changes overnight. But that overall, it has had a huge impact on their substance use and their risk factors associated with that unregulated stimulant use. So, for the final subtheme, protective program, participants conveyed the ways in which the program protected them from those previous harms that they had experienced that we spoke about in a previous subtheme. So, the program went far beyond just reducing harms related to their unregulated stimulant use. And I thought that was really powerful that people were speaking about that. So they emphasized things like, it impacted other places in their life, such as reducing adverse health events, minimizing their need to participate in criminalized behaviors. You can see on the screen there's someone speaking about, I've been out of the penitentiary for 8 months, and that was a huge change for them, very unusual. And people speaking about feeling like the program saved their life, or they're not having to do sex work anymore, or put their life on the line to be able to kind of survive day to day. So the major subthemes are complete, but I do want to jump quickly into a couple of different important questions that were posed to the participants. So we did specifically ask people about, how they were feeling about the possibility of programs potentially closing or scaling down. Um, you know, Overall, and this is something that we've actually asked people since the beginning of the reports, because the programs are funded it's always been time limited funding. This is something that we've always asked people to hear honestly from them about what it means to them. So in particular, participants really wanted to discuss kind of the potential consequences for themselves and for their community if they were to lose access to this program. So they spoke about things like, that this would destroy their life, that they're terrified of going backwards, and that they worry about not just for themselves, but their community, that a lot of people they're worried are going to die if these programs were to scale back or were to close. People also spoke really clearly about the harms that they felt would arise. So things like mental health concerns and feeling like they would have no choice but to use unregulated drugs because there wouldn't be any sort of kind of program that would fit the needs that they have. People worried a lot about going back to jail, going and being incarcerated again after potentially years of not being on in that system anymore, depending on how long they've been on the program and not been incarcerated. People spoke about things like having to, again, participate in criminalized behaviors and feeling like they couldn't think of a feasible way to manage their substance use otherwise without Safe Supply, and being really, really worried about that. So participants were eager to have the opportunity to advocate for themselves and their community, and we felt this was really important too. So people wanted to speak about things like, Safe Supply, it could save your life too. It bolsters wellness in the community. They don't want to be forgotten about. They don't want to be left behind or cut out. And feeling like Safe Supply gives them a purpose and a purpose to be alive, and struggling with the fact that they've lost so many people, and they themselves have had, really near-death experiences and are terrified to have to go back to that. Other people spoke about, being worried that policymakers and politicians might not understand, they might not get it and understand the impact of these programs. The fact that, people are losing family members, and even with the kind of limited safe supply programs that we have, we need more, not less. People speak about, if people are going to use drugs, as people have since the beginning of time, why not have something safe and tested? And why not have that available to people? A couple of interesting things that came up as well were surrounding kind of inequitable substance use care. So several participants expressed concerns for groups of people who use drugs they felt were lacking support and care overall with regards to substance use. So this included youth, people who are pregnant, LGBTQ community members, and others. And they really expressed fear and worry given the lack of care, even now, for these groups. People, explored, the fact that pregnant women, there's so much stigma, there's so much judgment, there's such minimal access for them, and that they deserve more. That, people who use crystal meth a lot of them are queer men, and that they are heavily marginalized because of their intersecting identities. And that youth right now, youth presentations to the ED, for example, in Ontario, have skyrocketed because of presentations related to unregulated drugs, and youth overdose have skyrocketed. And we don't have a ton of options for youth right now. And so they were really worried about what this meant for these groups. So we're getting to the end, but I always like to ask participants to imagine the future and ask them to describe what they would like to see. So a number of recommendations came out about kind of the future of the program, the evolution of the program, and kind of commonalities amongst what people were saying. So things that we've already discussed, people want more flexible programming, so other options for medication suspension, and adapting programs over time to meet needs. And that means a lot of different things. It means having, check-ins that meet their needs, programs available across the country, so that people can move around. It means many things: equitable care access for all of those different groups we had just discussed, and more. Again, medication options, care for adolescents and youth. People also spoke really clearly about the importance of wraparound care, so wanting to see expansions in what's available via wraparound care, so that things can kind of be tailored to the needs of individuals. And then as well, people spoke clearly more in this research than in the past about wanting help with social support. So seeking, reconnecting with loved ones and helping to rebuild or just build important relationships in their lives was really important. So that is it for the presentation. The full report will be released online soon. I've put the links to the substanceusehealth.ca. You can find it under evaluations. And then Safer Supply Ottawa also has a website where you'll be able to find the report. And that is it. Thank you so much, everyone, for coming. I appreciate all of you taking the time. It means a lot. Yeah, I would love to answer any questions, or if anybody had any comments they wanted to share. Thank you.
Thanks so much, Marlene. I have lots of thoughts, and we do have a few questions for you. Just before we do that, though, I am going to launch a poll, and I'd really appreciate it if people would take a couple of minutes just to fill that out. It's really important for our funding applications and for our current funders. But while you're checking the boxes for me, we can continue with start asking you some questions, Marlene. There are some clinical questions here, and I recognize that your capacity to answer that might be dependent on what information you have at your fingertips. I will also just say that with the community practice, with our clinician meeting, We do have a meeting coming up where we will be focusing on safer stimulant prescribing. So if you're not currently a member of the community practice, do join so that you can attend those meetings. Those meetings are restricted to members of the community practice. Okay, but the first question, what's the point for stimulant use?
Perfect. Great. That's a really good question. So it's about 0 0.1 grams of whatever drug they're saying they're using. So that's, yeah, so 10 points is a gram. That's how I like to kind of think of it, or yeah, that's how I like to think of it.
Thank you. And can you talk a little bit about what medications were prescribed to people? You very quickly threw in Ritalin, methylphenidate. Um,
Absolutely. Yes. So, like I said, the previous, I don't know if I think it was sent in the chat, but the second report, it's the spring 2023 report, has a lot of really detailed information about, like, I went and got really detailed information about the prescribing because I knew there would be an interest from people, understandably, about how they're prescribed. I would say most commonly, people are prescribed a combination of short acting and long acting. So they're usually prescribed a short-acting methylphenidate. Usually it's Ritalin 10 milligram tabs that they get a certain number of each day. And that typically is used to manage more of those cravings, kind of those in the moment cravings that people experience cravings to use crystal meth or to use cocaine or crack cocaine. And so that's the short acting. And then they usually, not everyone, but typically they're prescribed a long acting as well. And most commonly, that's like a long acting methylphenidate as well. But like I said, the report goes into a little bit more detail about all of the different variations that can happen. But the way I like to describe it is it's if you're familiar with Safer Opiate Supply, it's fairly similar in the sense of people are prescribed that short acting Dilaudid tabs or hydromorphone tabs. That's kind of how I think of the short acting Ritalin in this sense to manage cravings. And then they're prescribed their long acting as well, which for the opiates could be methadone, could be Suboxone, could be Kadian, or slow release oral morphine, all of those different sorts of things. And then so there's the long acting as well for people who use stimulants to manage more of kind of the withdrawal symptoms over time and kind of that sort of thing. So I hope that answers the question, but there's tons of information in the report I would encourage people to look at.
I just popped the
Yeah,
the link back in there as well. So,
great.
and I did see you had a chart in there that was really interesting around what the common doses are at intake versus at the time of data
Yeah.
collection there. So that looks interesting too.
Mhm.
Um, this is a great question from Cindy. With diversion of safer supply medication consistently in the media, I'm wondering if it came up in your research.
Mhm. So this time around, I mean, diversion always comes up a little bit, but with that kind of how we do the thematic analysis, of course, there's lots of things that aren't kind of said by enough people that it's not representative of the larger group and so wouldn't be included. So diversion, just to say, diversion always comes up in some form or another because you're right. It comes up in the media, but the participants, they're aware. They know that people are talking about it. They know that it's coming up in the media. So it didn't necessarily come up in a massive way in this research. What I would say, and I've opened the report myself, but the most recent report, not this one, but the one before, um, diversion, I think it was that one where diversion came up quite a bit. We addressed a lot actually in that report.
Mhm.
It was a really, really interesting research study. Yeah, so diversion came up quite a bit in that. And so what that was, I can just briefly touch on it, but what that was useful for was the clients spoke about diversion in the sense of why, like they answered the question as to why does it happen, because I think that's really important to getting down to kind of, yeah, I think the why kind of answers questions and can also answer questions about worries and different things like that. So people spoke broadly, and I've just pulled up the report, but they spoke broadly about things like safety. For people who are not on the programs, because I think we also need to keep in mind there are so many people who are not able to get onto a program who desperately need access to some sort of regulated substance because they are overdosing every day, they are really sick, and they're at imminent risk of dying because of how toxic the supply is. And so people spoke about safety in the sense of If they're you have people that you're really close with, they're not able to get on the program. I think many of us would struggle to look at our loved ones and say, I'm not helping you, when their lives were at risk day to day with what they were kind of consuming. And so people did speak about that sometimes safety was a reason why. They spoke about things like compassion, feeling like they remember being in that person's shoes. They remember if you've ever spoken to someone and asked them to describe particularly opiate withdrawal to you, I've had people say, I'd rather die or I'd rather get hit by a car. So people deeply empathize with what it's like to be in withdrawal from any sort of substance. And so compassion
Yeah.
does come up in that sense. Meeting needs comes up. So, for example, this was from a Safer Opiate Supply report, but people who were part of a Safer Opiate Supply program, many of them still do use stimulants as well, but for whatever reason couldn't get on a stimulant program because of capacity. And so they might trade a few of their drugs or divert a few of their drugs to be able to buy, crystal meth rather than doing sex work that day. And so that was a part of it as well. Survival was kind of ties into that as well, with kind of that surviving, not doing those criminalized behaviors, getting by. And then a couple of people did speak about pressure as well, kind of feeling pressured by others to share their safer supply. And I think this is very expected given the fact that if you're offering a resource to such a small number of people, of course, there's going to be pressure placed on them day to day. Yeah. So
Yeah.
it didn't come up in this report, but I hope that's useful.
I really appreciate you getting into that because that is, a lot of what we hear about in the media. And it is interesting because we aren't hearing about we're not hearing in the media about diverted safer supply medications or safer stimulant medications. And I'm not sure if that's a factor of um, the medications better meeting people's needs, or if it's a factor of it being just a very small program and not as common. It's very complicated. But
Yeah,
I also think it's great that what you're pointing out is that by understanding the why, that's how we can address prevention of diversion, right? Address the
yeah,
why.
adjust the
And
why.
there is a question here about strategies used to discourage or adjust diversion. And
Mm,
if I can take this one, if Marlene, if that's
sure.
okay, and you
Mhm.
can get specific about Ottawa if you like, but through the community of practice, we have a program operators meeting, and program operators get together and figure out how to ad- how to address different challenges that come up. And one of those challenges has been how do we identify and address the concern around diversion. And it is really about trying to meet clients' needs, and there are very strong protocols in place around everything from urine drug screening, really focusing on patient care. That is like having the right medication for the right patient, and the right dose for people. So making sure all of those things match as best as possible given the limited medication options that we currently have. And lots of conversations and trying to meet people's basic needs. That's a big piece of it as well. I'm super simplifying it, but if anybody wants to see those protocols, happy to share those with you. They are, yeah, we do have those available. Um, do you have time for a couple other questions, Marlene?
Yeah, I do. Yeah.
Okay, that's great. Did you want to add anything in about,
I
yeah,
think you covered it. I think
okay,
also just considering if we look at the culture of people who use drugs have always shared and have always taken care of one another,
yeah.
especially considering how rejected many of them feel and marginalized. And so I think we also need to remember that when we talk about diversion. But I think I'll leave it there.
Yeah, I really appreciate you saying that. And one of the other strategies for preventing diversion that programs wanted to do right from the very beginning was where, whenever possible, if there's a couple or people living together or close friends, have both people part of the program because it's, makes it very complicated if there's one person but not the other. Like an example of where people might end up sharing. So trying to get both people in the program, get both of their needs met, is an important piece of it. Um, oh boy, lots of questions coming in here. Um, so let me just go up because I've been sort of bopping around a little bit. Oh, do you know about the diagnosing people with ADHD before prescribing? You did bring up about how ADHD is something that people were grappling with and how their
Mhm.
substance use could reflect unmet needs in terms of ADHD. Yeah, do you want to talk about
Absolutely. So people know, so the short answer is no, people were not diagnosed with ADHD by the program before starting the program. Because I think again, contextualizing the program and that spring report from last year is useful for that as well. Because in addition to getting into the medication, it also gets into the intake process, who's prioritized for the program, things like that. So I think that would be useful as well to look at for some people. But no, so no, people did not have to be diagnosed with ADHD because what the program is addressing is it's addressing their stimulant use. So it's addressing their unregulated stimulant use, not any form of necessarily their ADHD. What came up in this was that people were self-describing as either I have a diagnosis of ADHD or I think I have ADHD. And so they were describing how they felt like that maybe, for example, maybe contributed to them starting to use unregulated stimulants
that?
because they weren't, caught as a child and assessed and given proper supports, or, so they think for themselves that maybe that's why they started using, or different things like that. That being said, many people, almost all of them, either again said either they have a diagnosis or they think they have ADHD. So no, I'm not diagnosing them. The teams aren't necessarily diagnosing them, but people were describing things in this way. And I think it's just interesting to note when we consider how to also, when we look at like across the lifespan, like prevention and things like this, clearly we need, more appropriate and rigorous screening for children in school to make sure that kids with ADHD or potentially or having symptoms of or whatever it might be are getting the care that they need. So yeah.
Yeah, I think so much of what this study and what you've been talking about today points to are how some of the issues that we are seeing and hearing about in the media, but seeing in our, in our communities, um, can be addressed by focusing on what the actual needs are, be it poverty, be it
Yeah.
access to healthcare providers, mental health, diagnoses and support, and all of that. So thanks, Marlene. Also, the very interesting statistics that you had there around people's experiences and the change in their experiences in terms of engaging in with criminalized behaviors. Um, so there's a question here about the protocols. And Rahim asked about the protocols, and I referred Rahim to our website where we have a number of protocols from different organizations. And
Mhm.
then I quickly realized that actually almost all of the ones we have on our website are focused on
Yeah. Mm.
safer opioid supply, and not stimulants. There is a BCCSU guidance for
Mhm.
safer or for stimulant use disorder,
Mhm. Mhm.
not specific to safer supply
Mhm.
stimulants. But yeah, there's that. And my understanding from attending clinical meetings, I'm not a clinician, uh, warning, warning, um, but that is a document that people refer to and
Mhm.
use to inform their practice.
Mhm.
But again, Raheem, if you are a member of the community practice, we'd love to have you come to our clinician meeting where we talk about how that works. Anything you want to
Can
add
I?
there?
Yeah,
Yeah.
I want to touch on that quickly because we have until 1:30, right? Am I right or am I
Yeah.
wrong?
Yeah, we
Okay.
do.
So this is something that's come up quite a bit with yeah, the protocols and people talk and how we're collecting data about people's substance use. So I just want to really quickly walk everyone through this because I think it'll make more sense if I do.
Right.
So all of the things that were discussed, I think I had pretty clearly outlined that it's all self-reported data, right? So it's all we ask the clients to speak to certain things. The reason why we do this, and this is kind of me also putting my my clinician hat on, my nursing hat on, is if we think about how we would understand how people are using drugs, and we think about the state of the toxic unregulated drug supply, um, there isn't really a good way to understand how much someone is using in a day with regards to drugs, other than to just simply ask them.
Yes.
Urine drug screens can be useful. Personally, I know where I used to work, we didn't find them to be as useful, but the reason why was again because of the state of the drug supply. Someone might actually have stopped using, let's say, fentanyl altogether and be reporting that they're not using fentanyl because they're not going out, they're not buying fentanyl, they haven't done that this week, that hasn't happened. But then their urine drug screen comes back positive for fentanyl because the crack cocaine that they were using was tainted with fentanyl. And so it becomes this thing where if we're going to continue to have people rely on an unregulated drug supply, then there is no other way to collect data about the quantity of drugs that they're using, other than to ask them. And I would also point out that in many other clinical realms, asking your patient is 100% the standard of practice and very acceptable. So if somebody comes in for migraines, let's say, into your primary care provider, and they start treating them, there is no objective measurable way that they're going to find out if it's improving. What they're going to do is they're going to sit you down and say, how's it going? Let's re-rate your pain again. Tell me about, have your is your
Wow.
quality of life improved based on this scale? Are your ADLs or have your activities of daily living changed? Are you feeling better? And so I do think that if we walk through that process of understanding the toxic unregulated drug supply, then does make complete sense to ask people about their substance use
Yeah.
overall. Yeah.
Yeah. That makes a lot of sense to me.
Mhm.
Marlene, do you want to talk about the wraparound care and the involvement of peer counselors, people with lived experience in the team?
Yeah, I saw the question about peer counselors and supports. So I touched on it briefly at the beginning, but absolutely. So people with lived and living experience and peers have been really integrated into kind of the program as a whole from the start. They are some of the positions that were funded within the original kind of applications. I know personally from my own experience, I absolutely would not have been able to run the program without peer support. They were so important to developing relationships, developing trust, gaining understanding, reworking the ways that I thought about things. And so, yes, just to say that absolutely they're part of the programs. And then the wraparound supports, if there is a specific question, I mean, there was primary care, there's access to infectious disease care, there's for hepatitis C and HIV, there's things like mental health supports, counselors, housing workers. So, and those, to be completely transparent, those are the positions that were actually funded through SUAP, right? So like the physicians are not funded through SUAP. Prescribers were not funded through SUAP. Not at all. The funding from SUAP goes to the wraparound care and wraparound supports that existed within the programs. So I think I saw a question too about funding. So I
Yeah.
can't get into the exact details. You'd have to email the program coordinator lead. That's just not my job to know. But I do know that generally speaking, the funding that came in did not go to prescribers. It went to the wraparound care supports. Yeah.
Yeah, yeah, yeah. That's true for many of the programs. Some who didn't have capacity did
Yeah.
use that program funding or use that funding to hire nurse practitioners to provide
Mhm.
care, and nurse
Yes.
practitioners have
To be
been.
clear, it's just Ottawa I'm speaking of. Yeah, for sure.
Yeah, and a
Absolutely.
couple of the others, but
Okay.
the
Yeah.
nurse practitioners have been such a huge instrumental group,
Huge.
moving this work forward, and working with researchers and people who use drugs to make sure that this is happening in an effective way. So yes, we have somebody asking about the funding, and it has been through Health Canada. The funding does end in March of 2025. So, and yeah, so a lot of programs are figuring out sustainability and pieces like that. And as you say, Marlene, for a few programs who do have uh, providers on staff, particularly physicians, then the prescription might still be available for people, but they are likely to lose all of, well, yeah, very, very likely to lose all that wraparound care that provides so much support and
Mhm.
really aids in the stability and the safety of the program, right? It's the wraparound care
Yeah,
providers who are working with people every day. Um, yeah.
absolutely.
Um, there's a question here as well about interaction with police and law enforcement. So the question is, what
Mhm.
is the program interaction with police and law enforcement? You did
Sure.
discuss the changes in involvement in criminalized behaviors or activities, criminalized activities as a and we imagine that would go along with involvement with the criminal justice system. But what about the program at the program level?
Yeah, so here in Ottawa, we have a working group that meets at minimum monthly because there's so many great partners who are involved. It's such a really fantastic initiative, and the police are part of that. So we do have one of the people who's in leadership with Ottawa Police who kind of comes to those meetings and regularly attends, and um, the the uh, the program has a great relationship with the police and is actively working with the police along with paramedics and the hospitals and tons of other community groups that are really important to and also work with people who use drugs. Yeah.
Thanks. There's another question here about educational and vocational supports, since use of drugs may have interrupted education and vocational development. And actually, there's a project that's starting in BC
Mm,
shortly, that it's actually the only it's the only program that I know that's just been funded by Health Canada moving forward that has a component that will involve safer supply. And the emphasis of that program, or what that program is all about, is creating a vocational program and and opportunities to do work, and
mhm,
recognizing that key to being able to engage in work is having some stability in your life, and key to having some stability in your life is knowing what drugs you are taking and the impact that those drugs will have on your capacity to function that day.
mhm,
And I think a lot about some of the people who use drugs who work with the community of practice. And when they are on Safer Supply, they are able to like plan their drug use and manage their withdrawal symptoms and things like that, so that they are able to come and function in the way that they want to function and show up in the way they want to show up. Um, and how when that goes astray, or and they become dependent, if they have to use unregulated drugs, things can fall apart. um, so they are doing an educational or sorry, a vocational program that will incorporate as a tool to
mhm.
support people's stability the option of safer supply. So, um, do you want to, is there anything you can talk about the Ottawa program in terms of vocational opportunities or?
I think it just reemphasizes the importance of those wraparound supports. Anecdotally, not within the research, but personally in my clinical work, absolutely, I saw people go back to school. I saw people finish high school, enroll in college programs, with the support of those wraparound services, which whether it was peer counselors who helped them do that, or
Mm.
social workers who helped them do that. So absolutely, I have seen that happen with people, and I think it's a really important point. Richard, I appreciate you pointing it out because it's something that I'm going to think about as well in terms of looking at the future. And it's interesting to hear about the BC group doing it too. So important,
Yeah,
so
it's
important.
that
Yeah.
Kilala is doing that, the health center.
Mm,
And the other thing that comes to my mind with that too, Richard, is that when people are on Safer Supply, it pulls them out of that cycle of, that runs their day of trying to acquire substances, use substances, and the short duration of opioids or stimulants. That you're on that like forever cycle. And when you have a stable source, like you're taken out of that loop, and suddenly, we hear people talk about having a lot more time in their day. Um, and so having things to do is really, really important. And I think part of, yeah, what makes things work for folks. Um, Given the precarious nature of funding for the future of these programs, is any work happening to look at the ethics of discontinuing them?
yeah, absolutely. Yes. I think that I think, I don't want to speak for anyone, but I think all of the groups are looking at that. And what I would say is, and what's something that I've always thought of is kind of those original BC groups back in I think 2006 or earlier were doing the injectable opiate agonist therapy, and then the programs ended. The funding ended. I think it was different. It was research funding and not exactly the same. But a lot came out from those trials from the participants themselves about the trauma that they faced and their communities faced and the deaths that came about as a direct result of being kind of pulled off of the program. Because what it means is for Safer Supply or these previous studies is your options that you have left if Safer Supply were to end. And again, I think all of the programs are figuring out what's going to happen right now, so I can't speak to specifics at all. But if the programs were to end or even scale down or whatever it might be, is you're put back into a place with the same options that made your life so dangerous before, the same options that didn't work for you, the same programs that didn't work for you. And that's a really scary thing. So I think we can also look back to those studies, and the clients of those programs, they put out papers, they put out advocacy pieces. Like if you look it up, there's tons of stuff that comes up, and it's really, I have found it really impactful and meaningful to read and hear directly from them.
Thanks for that. We did a great webinar back in, I think it was February, March, and I'll pull it up in a second. I can't talk and do that at the same time, but looked at looking at the ethics of Safer Supply, and we did touch briefly on what it would mean to end the programs. And I do know right now that there's a lot of people going through a lot of moral distress, trying to figure out how to handle the loss of, or not, I shouldn't say the loss of funding, the ending of funding. Um, there's a question here about, asking for more information about the Health Canada ending support for Safer Supply. Health Canada has not, like, Health Canada as a bureaucracy it funds pilot projects, and through legislation, they're only allowed to fund for a maximum of 5 years. So we did know going into these programs or setting up these programs that funding would only be for 5 years. And some of the programs have had 5 years of funding, Ottawa being one, I believe. And others have only had a year or two. But the issue is around sustainability. Sustainability, the intention or the idea is that if a pilot project is successful, then the intervention or the project or the program would then start getting funding more from the province because the province is what's responsible for funding healthcare interventions or healthcare services. So what's happened is that the funding time period has ended for a number of programs in BC and in Ontario. And the hope is that the provinces pick it up, but the provinces aren't picking it up by and large. So trying to figure out how to support the people who are on programs, either transitioning them to other providers in the community, or looking for those wraparound supports to help support people. There's a question here as well about wraparound supports with the utility. Marlene, you take this one. Um, Without the wraparound support, is there still utility in the prescription?
Absolutely. Yes. I think that I Safer Supply is funded by Health Canada, and that funding for many of the programs, and that has been really important funding. And I wish that it wasn't that things weren't ending when kind of coming up. However, physicians and nurse practitioners can take it upon themselves to prescribe medications as appropriate for people. And so just because funding is ending doesn't mean Safer Supply has to. Again, I don't want to do it lightly, like, oh, it's fine, everything will be fine. But just to say that the program certainly won't end. Any physician, nurse practitioner in their own practice that feels as though it's within their scope and they have the knowledge to do so, and there's lots of great guidelines out there that can help with that, including we have an Ottawa specific guideline for opiates out as well, can take it upon themselves to do that. And so yeah, I hope people will continue, and I think there is benefit to doing it on its own. I think it's just important to understand the importance of the wraparound care and how impactful that was for people. That's all.
Yeah, yeah, I agree. Um, I'm just looking up about the budget. It is online, so I will get that.
Yeah, I wouldn't know the budget off the top of my head. Sorry, not my
That's
area.
okay. I'm just finding it here, and I did pop the link to the ethics webinar in the chat there as well, if anybody's interested in that. That was a really a great presentation. Okay, here it is. I think it was um, 7 million over 5 years, 4 years. Yeah, 7.7 million over 4 years. And it's the biggest program in how many clients again?
I think we're over 500 now. Like I know I said
Yeah,
400 and something, but that was from months ago. I think it's over
yeah,
500. Yeah.
yeah. Great. Okay, well, we're at 127, folks. Thanks so much, Marlene. It's great to hear. And I think it's fantastic the way that you have been doing the evaluations where you've focused in on different pieces and been releasing reports consistently throughout the time of the project of the funded part of the program. And um, the evaluations have been, very useful for folks trying to develop programs and work with people. So yeah, thanks so much. I'm just going to also just give a little thanks to Katie and Tanya for helping me out with the chat and the Q&As and everything today. Really appreciate you both being with me. And Marlene, thanks. We look forward to the next report. Oh, do you have a focus for the next report, or is there a next report given the funding situation?
We're not sure, but all of you will be the first to know. So we're going to be
That's
doing
great.
something, but it's going to be a little bit different. Yeah. Yeah.
Great. Okay.
Yeah, it's
And
exciting.
it's very good. And I'm showing you my screen here. Just I wanted to, oh, again, just do a quick plug for our October 31st webinar, where we have where you can learn about the Safer Supply program in Thunder Bay. And there we go. Okay, everybody, thanks so much. Have a great day, and we'll hope to see you at our next webinar. Be well, everyone. And I will stop.